Okay, let's unpack this. Imagine you spot a strange, maybe worsening sore on your pet. Your mind probably races, right?
Oh,
You
absolutely.
think, what is that? And sometimes, just sometimes, the tiny culprit is one you might dread, a spider.
Hmm.
For this deep dive, we're tackling a topic that's challenging, often scary for pet owners, and honestly, surprisingly tricky even for veterinarians.
It really is. Brown recluse spider bites in dogs and cats.
Exactly.
And we've taken, a stack of your sources wading through the latest research, clinical management guides,
Looking at identification, symptoms.
how you even diagnose something like this and what the treatment options actually are, all focused on what the vets call loxoscelism.
Right, loxoscelism. And our mission today is to pull out the absolutely critical insights from all this. What makes these bites different?
Why are they so hard to pin down?
Yeah, and what's the reality of treating them? And, most importantly for you listening, what are the absolute need-to-know facts?
So let's start with the suspect itself. The brown recluse. The species we're usually talking about in the U.S. is Loxosceles reclusa.
Okay, so if you were trying to ID one, what are the key things? What should people look for?
Well, the most famous one, though it's not always easy to see clearly, is that dark, violin-shaped mark on its cephalothorax.
The cephalothorax. That's the head and body part fused together where the legs are.
Exactly. And the neck of the violin points back towards the abdomen.
The little fiddle on its back. That's the picture people have in their heads.
That's the one. But here's a detail that's actually more reliable, scientifically speaking, though you'd need a really close look.
Okay.
Unlike most spiders with 8 eyes, brown recluses only have 6, and they're arranged in pairs 2, 2, and 2.
6 eyes in pairs. Interesting. And size-wise, are they big, scary spiders?
No, not really. They're typically only about ½ an inch to maybe an inch long. Pretty small, actually.
And critically important, you mentioned geography. Where do these guys actually live? Because that seems like a huge clue.
It's absolutely crucial. They are overwhelmingly found in the south-central United States.
Okay, South Central, like where?
Think the Midwest, stretching down through the Gulf Coast states. Now, there are other related loxosceles species in parts of the Southwest.
Like California, Arizona?
Yeah, eastern Southern California, western Arizona, southern New Mexico.
Yeah.
But the reclusa, the main one we're talking about, is primarily central U.S.
So if you're, say, in New England or the Pacific Northwest?
The chances of a random sore being a brown recluse bite plummet dramatically. Location is key for diagnosis.
Okay, so specific look, specific location. What about how they act? Are they aggressive? Are they hunting pets?
Thankfully, no. Their name recluse is spot on. They're shy, they're non-aggressive.
They hide.
Exactly. Bites almost always happen defensively, like when a pet accidentally traps the spider.
How so?
Picture a dog lying down on bedding where a spider's hiding, or maybe disturbing stuff in a cluttered basement or garage. The pet presses against the spider feels threatened and bites.
Makes sense. And you mentioned their fangs are small.
Yeah, relatively small. Which means a bite itself might not even feel like much at first. Maybe a tiny sting or nothing.
Which leads us into why these bites are such a problem if the initial bite isn't bad. What's in the venom?
Okay, so the venom is primarily cytotoxic.
Meaning cell damaging?
Yes, directly damages cells and tissues. And it's also hemotoxic.
Affecting the blood.
Right. So cytotoxic and hemotoxic, potent stuff.
Is there one specific chemical that's the main troublemaker?
There is. The key enzyme, the one responsible for the really characteristic damage, is called sphingomyelinase D.
Sphingomyelinase D. Okay, definitely not something you hear every day. How does that enzyme cause the kind of nasty lesions we sometimes see?
Well, it basically attacks cell membranes. It causes direct tissue destruction, that's the necrosis, the dead tissue.
Okay.
It also damages the small blood vessels in the area, which messes up blood flow, and it triggers a really significant inflammatory response.
So it's a triple whammy.
Yeah.
Direct damage, blood vessel damage, and inflammation.
Exactly. That combination leads to those characteristic, often severe skin lesions, and in rarer cases, that hemotoxic component can cause red blood cells to break down hemolysis.
Anemia.
Yes, leading to anemia. And even less commonly, it can interfere with blood clotting, causing coagulopathy.
Now, here's where it gets, like you said, really tricky for owners. The initial bite is often painless or just a mild sting.
Precisely, which means most of the time, nobody sees the bite happen.
Right, you don't connect the dots.
And that delay in recognition is a huge factor. The venom's already doing its work before anyone even suspects a problem.
So you miss the bite, but then hours, maybe a day or two later, something starts to look off.
Yeah.
Let's walk through those stages the sources describe. What usually happens first?
Well, the initial stage, maybe minutes up to about 8 hours after the bite, is often missed entirely. Like we said, painless, or maybe just a tiny red bump, maybe a little itchy.
Nothing that screams emergency yet.
Not usually. Then you move into the early cutaneous stage, say 2 to 12 hours post-bite. Now you start noticing more.
Okay, like,
Increasing pain, maybe some swelling, more noticeable redness. A little blister might start to form right in the center. Itching often increases too.
okay, getting more noticeable. And then comes the stage that really defines these bites, right? The scary part.
That's the necrotic stage. This usually starts developing from about 12 hours onward, but it can progress significantly over the next, say, 2 to 3 weeks.
Weeks, wow.
Yeah, it's a slow burn. And this necrotic lesion is the most common and, frankly, the most significant issue. That little blister we mentioned, it gets bigger, darker.
And this is where the bullseye comes in.
Often, yes. It develops that classic bullseye lesion. You get a ring of redness or inflammation
Okay.
surrounding a paler, almost white or bluish center. That pale area is where the blood supply is getting choked off by the venom ischemia.
Ischemia, lack of blood flow.
Right. And over the next few days, that pale center turns darker, bluish gray, maybe purplish. The tissue there becomes firm, kind of dry, cool to the touch.
So that's the tissue actually dying off.
That's exactly what's happening. Over days to weeks, this ischemic tissue becomes fully necrotic dead. It forms a black, tough, leathery scab. The technical term is an eschar.
An eschar. Okay.
And eventually, that eschar sloughs off, it falls away, leaving behind a deep, open ulcer. And the really frustrating thing is, that ulcer can keep getting bigger for a while, sometimes digging down into deeper tissues like muscle.
That sounds like a really long, difficult healing process.
It is. The healing stage can take weeks to several months. That deep ulcer has to slowly fill in with new tissue, called granulation tissue, and contract. And it almost always leaves a permanent scar.
You mentioned systemic issues are rare but severe. If the venom does get into the system, what does that look like?
Right, systemic loxoscelism. It's uncommon, thankfully. It seems maybe more likely in smaller pets or if they got multiple bites.
In the signs.
You'd see more general signs of illness, fever, maybe acting really tired or weak.
Lethargy?
Yeah, lethargy, vomiting, not wanting to eat, maybe muscle aches.
And related to that hematoxic blood effect.
Yes, signs of hemolysis, the red blood cell destruction. So you might notice pale gums.
Anemia, again.
Right? Maybe jaundice or icterus. That's a yellow tinge to the gums, skin, or the whites of the eyes. And importantly, hemoglobinuria.
Which is?
Red or brown-colored urine because of all the hemoglobin released from the broken red blood cells spilling into the urine.
Okay, that sounds serious.
It is. And then even rarer but more severe complications can include acute kidney injury, often because the kidneys get damaged by all that hemoglobin or direct venom effects.
Wow.
Very rarely, low platelets called thrombocytopenia or a serious clotting disorder called DIC, and things like seizures or coma are extremely rare, thankfully.
One interesting point from the sources, bites in fatty areas can be worse.
Yeah, that's an observation. Envenomations in areas with more fat, like the flank or belly, sometimes seem to develop larger, more significant lesions. Maybe the venom spreads differently or persists longer in fat tissue, but the exact reason isn't totally clear.
This all brings up a huge question. If the bite is often unseen, and there's no simple Recluse test you can run, how do vets actually diagnose this? It sounds incredibly challenging.
It is. It's one of the biggest challenges. Definitive diagnosis is honestly very difficult in veterinary medicine. It's almost always what we call a presumptive diagnosis. Meaning it's based on putting the pieces together, seeing that characteristic lesion, especially how it changes over time.
That progression we talked about.
Exactly. Knowing the pet lives in or recently visited a geographic area where these spiders live.
The endemic zone.
Right. And then, critically, ruling out all the other things that could cause a similar-looking sore.
So what information does a vet absolutely need from the owner?
History is vital. Was any kind of bite or sting witnessed or even suspected? When did it happen? Where has the pet been recently confirming they're in that endemic range? And the timeline is crucial. When did you first notice the lesion? How has it changed, gotten bigger, changed color, blister?
And the physical exam.
The vet will look very closely at the lesion itself. Size, color, presence of a blister or that eschar swelling pain level. And they'll check for those systemic signs, fever, lethargy, pale gums, jaundice.
What about lab tests? Blood work? Urine tests.
Labs are important, but not usually to diagnose the bite itself. There's no marker for the venom, typically.
So what are they looking for?
They're looking for two main things: ruling out other causes, like a bad infection, and assessing for those systemic complications. So, a complete blood count, or CBC, checks for anemia from hemolysis or signs of inflammation or infection. A serum biochemistry panel checks kidney function, liver enzymes, muscle enzymes, and a urinalysis looks for that pigmenturia, the abnormal urine color from hemolysis.
Okay. And maybe clotting tests if things look really severe.
Yeah, coagulation profiles might be run if there's suspicion of DIC or bleeding issues, but again, that's pretty uncommon.
You keep mentioning ruling other things out. Why is that differential diagnosis part so absolutely critical here?
Because so many other conditions can look identical to a brown recluse bite, especially early on before that classic necrotic eschar forms, your sources really hammer this point home.
How common is misdiagnosis?
In humans, it's estimated that something like 60% of cases diagnosed as brown recluse bites are actually something else entirely. 60%.
Wow, that's huge. 60% are wrong.
Often, yes. And frequently, these misdiagnoses happen outside the spider's known range, which should be a big red flag.
So what kind of things get mistaken for it, like a bad bacterial infection?
Absolutely. Aggressive bacterial infections, things like MRSA, are notorious mimics. Abscesses, cellulitis, deep skin infections.
What else?
Certain fungal infections, bites or stings from other insects or arthropods, sterile paniculitis, which is inflammation of the fat layer, trauma like burns or deep scrapes, vasculitis, which is blood vessel inflammation. Even some types of skin tumors or immune-mediated diseases can present with nasty-looking ulcerated lesions.
So the list is long.
Very long. That's why history, location, and careful workup are so essential. You have to rule the mimics out.
Okay, let's shift to treatment then. If a brown recluse bite is the strong suspicion, what's the plan?
The core of treatment is supportive care. There are clear goals: minimize the local tissue damage from the venom, manage the pain, which can be significant,
Right.
prevent or treat any secondary bacterial infection that tries to set up shop in that open wound, and then provide intensive support if those rare systemic problems show up.
And you mentioned earlier there's a really crucial piece missing from the toolkit in the U.S.
Yes, and this is a key takeaway for everyone listening. There is no commercially available antivenom for brown recluse spider bites in the United States.
None at all.
None approved or available for routine veterinary use here. Antivenom does exist and is used in places like Brazil and Mexico, but vets in the U.S. don't have access to it.
Wow. Okay, so without a specific antidote, that supportive local wound care becomes absolutely paramount, doesn't it?
It is the absolute mainstay of treatment. Yes. In the very early phase, like the first 24 to 48 hours, applying cool, moist compresses, not freezing cold, just cool for maybe 10-15 minutes several times a day might help.
How does that help?
It can help slow the enzymatic activity of the venom slightly and reduce inflammation, but, and this is critical, the sources emphasize this, avoid using ice packs directly on the skin.
Why no ice? Seems counterintuitive for inflammation.
Because intense cold can cause further vasoconstriction, clamping down of blood vessels, and actually worsen the tissue damage and necrosis in these specific types of wounds. So cool compresses, yes. Direct ice, no.
Got it. What else early on?
Keeping the area relatively still, if possible, clean and dry.
And then once that dead tissue, the eschar, forms and you have that open ulcer.
Then meticulous daily wound care becomes the focus, gently cleaning the wound, usually with sterile saline or maybe a very dilute antiseptic that isn't harsh on healing tissues.
And
yes, using appropriate dressings is really important. They help manage drainage, protect the wound, and promote a healthy healing environment. Your sources mention things like silver sulfatazine cream or medical-grade honey dressings often being beneficial.
Okay. What about cutting away that dead tissue? Surgically. Debridement.
This is another really crucial point where timing matters hugely. Surgical debridement of the necrotic tissue should generally be delayed.
Delayed? Why wait? Don't you want the dead stuff gone?
You do, eventually. But the venom can keep causing damage for days, even weeks. The full extent of the necrosis isn't clear early on. If you go in and cut tissue away too soon, you risk removing tissue that might have actually survived, making the final wound much larger than it needed to be.
I see. So you wait until the edges are clearly defined.
Exactly. Usually wait about 2, maybe 3 weeks, until the line between dead tissue and living tissue is very clear. Then, surgical debridement might be needed, and sometimes later on, skin grafting might be necessary to close a very large defect.
Are there things you should definitely not put on the wound when cleaning? Things to avoid.
Yes. Avoid harsh antiseptics like full-strength hydrogen peroxide or povidone iodine. They can actually be cytotoxic, harmful to the new cells trying to heal the wound.
Okay.
And definitely avoid applying heat. Heat can increase inflammation and venom activity.
Makes sense. Now, pain management. You said these can be very painful.
Yes, often extremely painful, especially as the ulcer develops. So pain control is essential not just for comfort, but for overall well-being and healing.
What's typically used?
Opioids are often the mainstay for moderate to severe pain associated with these lesions. Things like buprenorphine, fentanyl, or others, depending on the situation.
What about NSAIDs, like carprofen or meloxicam?
NSAIDs can be used for mild to moderate pain, but with caution. Vets need to be careful, especially if there's any concern about kidney function, remembering AKI is a rare complication, or if there are potential effects on platelets, though that's less common. So opioids are often preferred, especially initially.
Okay. What about other drugs? Things like steroids or antibiotics? Are they standard?
This is where things get controversial, or the indications become very specific. Let's take corticosteroids, like prednisone.
Okay.
They are highly controversial and generally not recommended for routine use in these cases.
Why not? They reduce inflammation. Right.
They do, but the evidence just isn't there to show they actually limit the necrosis, the tissue death. And worse, steroids can impair wound healing and significantly increase the risk of secondary bacterial infection in that already compromised wound.
So generally avoid steroids.
Generally, yes. Maybe a very short course could be considered in extremely severe systemic inflammation cases, but for the local wound, the consensus from the sources is largely against routine use.
I saw dapsone mentioned in some human literature for these bites. Is that used in pets?
Dapsone is interesting. There's some weak evidence in humans suggesting it might help limit lesion size if given very, very early, like within 24 to 48 hours.
But in pets?
Its use in veterinary medicine is much more limited. It has potential side effects, particularly affecting red blood cells, so it requires careful monitoring. And the studies in animals have really shown mixed or inconclusive results. It's not a standard go-to treatment.
Okay. And antibiotics. Do all these bites get antibiotics?
No, definitely not automatically. Antibiotics are only indicated if a secondary bacterial infection is clearly suspected or confirmed.
How would you know?
Signs like increased pus, worsening redness and swelling spreading from the wound, maybe a foul odor, or if the pet develops systemic signs of infection like a persistent fever.
So, not for prevention.
Not for prevention. Using antibiotics unnecessarily contributes to resistance. If an infection is suspected, the ideal approach is to take a bacterial culture from the wound and do a sensitivity test to choose the most effective antibiotic.
What about antihistamines? Do they help?
They might help a little with itching or some of the initial swelling and redness, but there's no evidence they do anything to stop the necrotic process itself. So maybe for symptom relief early on, but not a core treatment for the main problem.
And for those rare pets that get really sick systemically?
Those cases require intensive supportive care, usually in the hospital. Aggressive 5e fluids are crucial for hydration, supporting blood pressure, and trying to protect the kidneys.
Blood transfusions, maybe?
Yes, if the anemia from hemolysis becomes severe, blood transfusions might be necessary. And just really close monitoring vital signs, urine output, repeated blood work to track kidney values, red blood cell counts, etc.
The sources also mentioned some therapies that were tried in the past but basically found not to work.
Right. It's good to know what not to pursue. Things like using antihistamines specifically to stop necrosis. Again, they don't. Colchicine. Anticoagulants, applying topical nitroglycerin, giving high doses of vitamin C, electric shock therapy, which was bizarrely proposed once.
Electric shock. Seriously.
Yeah, thankfully debunked. And as we discussed, systemic steroids generally fall into the not proven effective for the lesion category. Focusing on the core supportive care is key.
Okay, so a pet gets bitten, goes through all this supportive care and wound management. What's the long-term outlook? What should owners realistically expect?
For the most common scenario, which is just the local skin lesion without severe systemic problems, uncomplicated cutaneous loxoscelism, the prognosis is generally good.
Good, even though the wound looks terrible.
Yes. It looks awful, it's painful, and healing is frustratingly slow, weeks to months, definitely not days. But they do typically heal. The major long-term consequence is usually a permanent scar.
Okay. When does the outlook become more worrisome?
The prognosis gets downgraded to guarded or even poor if those rare systemic complications happen, like severe hemolysis needing transfusions, acute kidney injury, or DIC.
What else makes it worse?
Also, if the local lesion is just massive or extremely deep, or if it gets severely infected and that infection isn't controlled, significant delay in starting appropriate treatment can worsen the outcome too. And as you might expect, very small pets or those with other underlying health issues might have a tougher time healing.
Are these bites ever fatal?
Fatalities are extremely rare, but yes, they have been reported, almost always in association with those severe systemic complications like kidney failure or DIC.
So that long healing process means monitoring and follow-up are absolutely essential.
Critical. Any pet showing potential systemic signs or with a very large or rapidly expanding lesion really needs to be hospitalized initially, maybe for 24-48 hours, just for close observation and stabilization.
And after they go home.
Frequent recheck appointments with the vet are vital, maybe weekly, sometimes more often early on. The vet needs to assess the wound, clean it properly, change bandages using the right technique, and just monitor the healing progress.
And the owner's role at home sounds pretty intensive.
It absolutely is. Owners have to be really diligent. They need to follow the vet's instructions for home wound care, precisely cleaning, applying medications or dressings.
And the dreaded cone.
And yes, preventing the pet from licking, chewing, or scratching at the wound is non-negotiable. That usually means an Elizabethan collar or e-collar, often for weeks, even if the pet hates it. Licking can introduce infection and severely delay healing.
Which brings us to owner education. It sounds like setting expectations and giving really clear instructions are maybe the most important things a vet can do.
Absolutely. Managing expectations right from the start is key. Owners need to understand this isn't a quick fix.
Right. Explain the timeline.
Explain that healing will likely be slow, taking weeks or months, not days, and that a permanent scar is almost unavoidable. It's also important to gently reiterate that there isn't a magic bullet, no specific U.S. antivenom, so the treatment is the supportive care and the wound management.
And giving them those crystal clear home care steps.
Yes. Detailed, maybe even written or demonstrated instructions. How to clean, what to use, how to apply the dressing, how often. And crucially, what specific signs to watch for that might mean infection is setting in or things are getting worse, prompting an immediate callback to the clinic.
Okay, finally, let's talk prevention, especially for listeners who live in those south central U.S. areas where brown recluses are common. What can people do?
Prevention is definitely better than cure here. The main thing is habitat control around the home.
Like what?
Reduce clutter. Basements, garages, sheds, closets, wood piles, these are prime recluse hideouts. Keep storage areas tidy. Seal up cracks and crevices in the foundation or around windows and doors where spiders might get in.
What about bedding and things pets lie on?
Good point. Shake out pet bedding regularly, especially if it's been stored. Same for blankets or clothes left on the floor. Be cautious when moving stored boxes or items.
And pest control services.
If you know you have a significant infestation, consulting a professional exterminator can be helpful. Just make absolutely sure that any products they use are safe for your pets, both during and after the application. Discuss pet safety with them beforehand.
And just general awareness, I suppose.
Yeah, just being aware. If you live in an endemic area, be a bit more vigilant about unexplained sores on your pets. Don't panic over every little bump, but seek vet care promptly for anything that looks suspicious or isn't healing normally.
Now, for people outside that main recluse zone who might see a brown spider and worry or have a pet with a weird sore, is there anything to help them rule out a brown recluse?
Yes, that's a great point. There's a helpful mnemonic often used in human medicine, but it applies here too, called not recluse. It helps you spot features that are not typical of a brown recluse, especially if you're outside the endemic zone.
Okay, not recluse. How does that work?
So N is for no distinct violin mark, or the marking isn't clear fiddle-shaped. O is for one uniform color on the legs, and abdomen recluses don't have stripes or patterns there. T is for two main body parts, like most spiders, but they lack really obvious segmentation otherwise.
Okay, NOT.
R is for reclusive behavior they hide. They aren't usually found wandering out in the open unless disturbed. S is for 6 eyes, not 8, which most other spiders have.
Right, the 6 eyes in pairs.
Exactly. And E is for that specific eye pattern, the pairs. 2, 2, 2, 2. So if you see a brown spider that, say, clearly has 8 eyes or has striped legs and you live somewhere like Oregon or Maine, It's extremely unlikely to be a brown recluse. It helps put things in perspective.
That's actually really helpful, not recluse.
Okay.
So we've taken a really deep dive into what is clearly a complex and pretty concerning issue.
Yeah.
Brown recluse spider bites in pets. It's marked by that sneaky start, right? The unseen bite.
The insidious onset.
Yeah. And then the potential for really severe tissue damage, that necrosis. And a treatment plan that, fascinatingly, relies entirely on supportive care and just really good wound management because, well, there's no widely available antivenom here in the U.S.
Right. This whole discussion really highlights the absolute importance of geography, knowing where these spiders live. Recognizing that potential but not always present bullseye lesion and the slow necrotic way it develops.
And appreciating how tough diagnosis is.
Hugely tough. And how often it's misdiagnosed. Plus, the critical role of just good, solid, supportive wound care, knowing what to do, and just as importantly, what not to do, like using ice or debriding too early.
And prevention, of course, in those areas.
Absolutely, the power of prevention.
Okay, so given all this, the difficulty in actually confirming these bites, that 60% misdiagnosis rate we talked about, and the sheer number of other things, infections, trauma, whatnot, that can look exactly the same, what really stands out to you about how owners and vets can best navigate this uncertainty together? How can they be alert to the possibility of a recluse bite while also feeling confident ruling it out when it's more likely something less sinister, like maybe a common bacterial infection?